And you don't say one. Oh, hi, back to us for the Q&A. That was a wonderful session, all three of you. Thank you so much. I have questions. Ready, set, go. Why is regular milk a no? This person drinks over a liter a day and her hydration specialist keeps asking her not to, him or her. Isn't it better than drinking nothing? There's short bowel syndrome, high output jejunostomy on Revestive, which is the Canadian equivalent to get it.
Yes.
Sure.
Okay.
So, Joan, I can take a shot at that. In general, ultimately, milk may be okay for patients with short bowel, but we caution patients against taking milk, and particularly whole milk, for two reasons. Number one, there's a very high incidence of milk allergy in these patients with lactose intolerance. So if that is the case, they will do better, even perhaps with soy milk or some substitute. That's number one. Whole milk better than skim milk because it does have some additional sugar. And ultimately, it comes down to milk and plain water. So that's the reason milk with caution.
Okay. Well, that's the quickest answer you've ever given, Dr. Iyer. Congratulations.
That's the best question you've ever asked me, Joan.
And I have the bouncer here with me, our founder, Dr. Lynn Howard. So you have to be spot on. The next question is, what kind of bread is best? The slide says avoid fiber, but also says eat complex carbohydrate bread. So,
Everyone, so I'll take this one. Diet, there aren't really good blanket rules. And I think this is one of the things Kishore and I tried to convey is in the end, everyone has to live their own experience and they have to develop and figure out what works for them. So his advice about milk, we start off and when we're saying, maybe it's not your initial go-to, but then you try it. And if it goes okay, well, then you can introduce it. And bread and bread products are the same. It isn't that there's one that's better or something else that's 100% better than other things. Sometimes when people are really short, we're actually looking to try to get soluble fiber that can get into your colon, get broken down by the bacteria in your colon and turned into short chain fatty acids, which you can absorb as a calorie source. And so that's a way to try to get calories using your colon and not your small bowel. So I would love to be able to tell you, eat this magical 7-grain bread and you'll poop once a day and everything will be fine, but you have to live it. And so you work with your team, get a diet, get your dietitian, get your docs, and keep a diary. Journal what happens. Try something. Try a kind of bread. If it goes great, rock and roll. If it doesn't, then don't do it. Or Kishore said one time in our talk about cheating, like the cheat. So I'm not supposed to do that. You have to do it, right? Who goes through life without ever having a piece of birthday cake? Who doesn't want to have an ice cream cone on a hot day? So you do those things. And you accept that, I know the price that I'm going to pay. And if the price isn't so bad, then cool, go for it. But everybody, you have to experiment. You have to try things. And you should do it where you're recording the information and you're ultimately getting feedback from your team.
All right, I'm going to take this opportunity to invite the audience to send their questions forward through the chat feature function. Next question, are there any children who have come off of TPN using teduglutide who have ultra short bowel?
Yes, the short answer is yes. Just this in clinic last week, now this isn't even a teduglutide child, this was a little girl, who's got 8 centimeters of ileum and then her colon, but literally duodenum, 8 centimeters of ileum and colon, and she's off TPN, and frankly, we're probably going to take her off of tube feeds, and she's not on teduglutide. But we had, in the trial, we had patients come off, including ultra shorts, and in the group that we have right now, we have patients coming off, so yes. So for anyone who doesn't know, the designation ultra short bowel is a little bit variable, but it just refers to the really, really more challenging patients. So sometimes people say that's under 30 centimeters, or maybe it's under 20. We published a paper, about 8 years ago on our ultra short results here in Nebraska, where we looked at all of our patients that were under 20. So we were looking at a median of about 12 centimeters of intestine. And we showed that 50% of those children were off of TPN in 2 years. So with the era of growth factors, folks, I think we're getting to an era where I'm not sure that any bowel is too short in pediatrics.
Joan, there's one interesting addition to that, which is that even in our adult experience, we have patients who have residual bowel in the single digit, 6 centimeters, 9 centimeters of TPN, aided by additional colon. And one way to look at this issue is, in some ways, paradoxically, the patients who have even less small bowel respond better, because patients who have some ileum and their right colon, they already have some what we call endogenous GLP-2. Their intestine is already secreting GLP-2, so the effect you're trying to get from the drug is extra. Whereas for the patients who are ultra short, like David just described, for them the GLP-2 is almost replacement therapy. It's like treating insulin-dependent diabetes with insulin. You get a good response when you replace the hormone, and that's in a sense what is happening.
Well, thank you. Thank you so much. Next question. Well, we have one nice comment. This was a fabulous session, so we thank them for sending that forward. Okay, this one is a little more complicated, so I want you to both listen carefully. I was born with stomach cancer, had major radiation and chemo as an infant, first to get actinomycin D in 1963 trial through Cardinal Glennon in St. Louis. I've survived, and at age 57 started having issues in my 40s. ER, dehydration, levels off, Gattex and TPN not working, extremely tired, and now on tincture of opium, low dose, from bathroom 15 times a day to 2 to 3. Now on hydration, magnesium, potassium, IV daily. What's next when Gattex TPN doesn't work for short bowel syndrome?
David, you go first.
Okay. Well, it's obviously that's a complex scenario. So my first answer is sort of I don't want it to sound conceited, but it's gonna sound conceited, which is, it depends a little bit on where you are and who's looking after you right now. And no aspersion on whoever that is, and hopefully it's not me and I'm saying anything about myself. I don't recognize the scenario, so it probably isn't. But I think before I would say those things aren't working, I would want to know that that person was being seen in one of what I would argue is a very limited number of centers in the United States that look after adults. I'd like to think we're one of those. I think Kishore is one, and we can certainly make recommendations of a few other places that are geographically closer to wherever this person is. But it isn't just enough to say that your gastroenterologist has said that, they have some interest or something. You really need to be before you go down another pathway, you need to be in a what I would say is one of the real hardcore, one of the main centers, and at least get an opinion. What is left for you? If you're a patient who, if you've optimized everything medically, everything surgically, you've been on a growth factor that's been optimized and it's being done correctly and everything else, and you're still on TPN, well, then the question is, well, how's that going for you? Because if you're on TPN, but life is okay and you're doing everything that you want to do, and you're not suffering ill effects, then good. You're a winner and everything is going fine. And we would do everything we can to make your life as free and as good as it can be. If that isn't the case and you have bad complications and everything else, and you failed everything else that we can come up with, that's when we start to talk about, is that a patient who's a candidate for transplant or not? But
I want to just add a comment here. I want to echo what David said, and it always risks. We obviously don't know the specific scenario here. We may not know important details. We don't know who's looking after, but I think that is an important consideration. One question that crossed my mind as you were giving us those details. Uh, I didn't hear that this person had bowel removed or has short bowel. And if you said that already, I apologize. But one has to wonder, if there was no bowel removed, whether what we're looking at is not actually short bowel consequences, but rather consequences of radiation
Yeah.
enteritis.
Yeah.
And in fact, what I would think, just looking at the timing of how this played out, if this was an actinomycin C trial, that's it, we're talking an era when less was known about protecting the bowel from the ill effects of excessive radiation. So this could be radiation enteritis and a functional disease, not a consequence of loss of bowel, in which case Gattex may not even have a role.
Yeah. And
Yeah, well, the way the question was phrased was, what's next when Gattex and TPN doesn't work for short bowel syndrome? So I'm assuming it is short bowel, but
Yeah.
I could be wrong.
It may be, though not to be facetious here, but it may be, to go back to what David said and make sure, when you're saying what's next, to be certain that what was before was done correctly.
It's very common, in my practice, for patients to show up on Gattex and we stop it.
Yeah.
Because we don't feel like it was ever indicated in the first place. Because, if you're on Gattex and drinking 8 cans of Mountain Dew a day, Gattex isn't going to do anything for you until you look after the details and optimize it as per that algorithm, which was really nice, the Francisca Jolie algorithm. Until you've done all of the steps above that, you may very well not get the benefit from that. So there are things that can happen after that. So, but I think you would just, from my own perspective, I'd have to have a handle on that patient directly, or at Kishore, or one of a handful of other places.
Right. Well, thanks so much for those responses. My next question is, since you've opened the door to this, could you explain, how does someone begin to think about how they're being managed and how they might tap into one of the few intestinal failure centers? I mean, it can't be easy, because lots of times you're crossing state lines. You have the reimbursement mechanism to consider. But, I believe it's very important. And if you could touch on how you might work with local clinicians for the management of the patient after they've been seen by you and the center.
Go ahead, Kishore.
This is an important question and a difficult one. From my time in Omaha, I can tell you that in Omaha, look, why does Omaha, in the middle of nowhere, Nebraska, don't be offended, David, but really, no, I say this with a lot of affection, have a premier transplant program and a premier intestinal failure program. It's because there are people with an interest and expertise. So, and Omaha got a lot of patients from out of state, just like we get a lot of patients from out of state. We draw patients from a 5-state area, the 5 big states, and then the Northeast. But it's tricky for people to be able to travel, insurance, all of those things. But I think if you have a good local care provider, that could be a primary care doctor, it could be a gastroenterologist, it could even be a surgeon who wants to engage, wants to provide the care, acknowledges that there may be some things he or she doesn't know, and then perhaps the patient comes once in 6 months, once a year, to an Omaha or a Mount Sinai or a Cleveland Clinic or a Mayo Clinic. I'm just naming some names.
Yeah.
These might not be right. You just, those centers then provide a slightly bigger 30,000-foot view, and you help the local care provider provide more day-to-day management. David?
Well, and what I would say, if I was someone at home and I was wondering, do I need to, what do I need to do next? I think the questions you need to think to yourself are, who's in my corner? Do I know what the plan is for me? Do I know what their plan is with respect to how my TPN is being managed? Do I understand what's going on? If I have a question, who do I call? If I call an office, do I get told that, well, there's not any appointments, for 3 months, but we'll get you in then? Or is there someone on the other side who understands what I'm calling about, who can give me advice? Do you have a dietitian that you interact with regularly? Is there someone who is like a friend that you can call them up and you can say, hey, I'm struggling with this. What do you think I should do? If you feel like you're on an island and you don't have that, and many clinicians with the best of intentions are doing their best, but this is not easy. This is a tough life for you. And if you want the best, I think you have to be sitting and you have to be saying, do I have those things? Do I have someone I can call who I know that, they're in my corner on the other side? And coming to one of the big centers, as Kishore said, this doesn't have to mean that you're here every week and you're upending your life and everything else. But if you can afford to take a few days and go somewhere and get a comprehensive evaluation, we can do a ton in just getting to meet someone, and a ton of stuff by email and telephone and seeing someone once or twice a year. And it can be life-changing just to go through that process. So I think you just have to think in your heart, do I feel like I'm well supported, and do I know what's going on? And if you don't know what's going on, or you don't feel well supported, then you go to a place like Oley and you say, where do I go? You find out where are the big centers. Kishore named what I would say are the premier places.
That's perfect answer. There are no more questions showing up, but Kishore, I'm wondering if you wouldn't mind giving a little promotional speech on Lift Echo for the clinicians that are out there.
I'd like that too, because we didn't get to that. I wanted to get to that in our talk, and we just didn't get to it. So yeah.
And I didn't want to jump the gun there, but it is appropriate to your last question, and David and I are involved with another group that is looking at this issue of, are there differences in care in different parts of the country? And we think there is. And it would be presumptuous of me to say that, oh, if you're getting care at Mount Sinai, it's the best there is, and or next to Omaha. But we do have a sense, at least, that if I speak about outcomes from Paris or Cleveland or Omaha, I may agree or disagree, but I will look at what David is saying very carefully, because I think this is a thoughtful group that's spending a lot of time looking at this. So one of the things that we started about a year ago, and Joan, of course, the Oley Foundation has been very heavily involved in this from the very beginning, is to start a project called the Lift Echo Project. And without getting too much into it, the Echo Project was first launched about 10 years ago by a hepatologist, by a liver doctor, to reduce differences in standards of care for hepatitis C. People were dying because they couldn't get to see a specialist in time. And there are many echo projects around the world. And I came across this and I thought, why not we do this for intestinal failure? So that's what we launched about a year ago. And the way it is, what it does is, I don't actually directly provide care for, say, somebody in Montana. But if there is a patient in Montana being managed by perhaps a non-specialist doctor who's doing the best he or she can do, but is not a specialist in this area, maybe a community gastroenterologist, what the Echo Clinic does is it provides a forum literally for learning about intestinal failure and home TPN. So we do a 1-hour clinic. In many academic centers, this is common. Once a week, the professor makes rounds for an hour. You talk about some cases, you learn about things, somebody gives a lecture, and that's called a professorial round. It's a bit like that. We do a 1-hour clinic once a week. Somebody presents a case from somewhere. The case is blinded, so we don't know who or what. But it's a clinician, a nutritionist, a doctor, a nurse, somebody presenting a case. We all then have a discussion with experts present to try and develop some recommendations on next steps. What do you do? For example, the case you presented, the case you talked about from St. Louis. Maybe the doctor would present that case. We would help them in terms of how they would present, and then we would facilitate a discussion to understand what the challenges are, what are the next steps, what should you think about, and then we complete each 1 hour clinic with a didactic. Not open to patients, but it's really open to non-specialist clinicians, doctors, nurses, nutritionists, and it's gone very, very well. We've done it for just over a year now, 2 clinics a month for adult topics, and we've just launched a pediatric clinic. And I'll tell you, we've had people sign in, doctors, nutritionists, pharmacists, sign in from 36 different US states, 15 countries outside the US. Last week, we had somebody present a case from Croatia. We had somebody present a didactic and expert topic from Manchester in England. So that's an option for not open to patients, but you could go back to your doctor and say, hey, have you heard about this? Can you present my case? Enough already.
Can you still hear me?
Yes, we can.
Oh, very good. Oh my God, I'm getting booted all over the place here. If there are no more questions and there's nothing else to share, we can end the session, give people a little break. We'll return for the award ceremony at 3 o'clock. But before we do, I want to thank Takeda for supporting this session. It was a good one. And the important thing is they support the session with a hands-off mentality. This has been planned by the Oley Foundation, and we couldn't be more grateful for the support. So thank you, the folks at Takeda USA. So with that, I'm concluding the session. Thank you so much, Dr. Mercer, Dr. Iyer, and Aeisha Reese.
Aeisha, good to see you. Take care, everybody.